Thank you, Jose. And I will present now our experience also in something that we always have in questioning in our meetings, which is acute lesions. I will show you how we're using these two technologies. In my group, we have physical therapists, and they use radial shockwaves for pain. And I don't agree with that very much. So we're fighting all the time, so we decided to make a study. That's what you have to do with your physical therapist when you have a problem. Have nothing to disclose, and no commercial or funds from any company were used for this study. Ankle sprains actually are the most common injury in sports traumatology. More than 1.5 million people consult every year to orthopedic surgeons in the States just because of ankle sprains. You know, according to the AOFAS and the classification of first, second, and third degree, depending on if it's a complete tear or not a complete tear with instability. The most common are these. The second degree sprains are the most common form. And they're usually treated very well with partial immobilization, bracing, physical therapy, controlled medication. But usually the recovery time is 4 to 6 weeks, like in one of our players that had to go out of the Selección Colombia and missed a couple of games just because of an ankle sprain. So the treatment, if we could do something to reduce this time, rehab is long and pain dependent, and the whole rehabilitation process is too long, maybe we could do something about it. The common complication is chronic instability, limited dorsiflexion, and that's one of these are basically mechanical ones, but they're usually solved by good physical therapy when it's a second degree. So the problem is pain control that may limit the ability to perform a proper rehabilitation process and reduce these complications. And the use of medications just to control pain is also bad in terms of doing the rehab process in our athletes. So the problem is pain, both acute or chronic. We could have some possible options to improve results. The two options that we use are radial shockwaves or high-intensity laser, plus all the rest of the physical therapy situations. I did not think that this was very good because it may cause pain and may cause more swelling. I didn't really know if we should use it or not, but my physical therapist used them. After a few years ago, we started using high-intensity laser, which also has a fair or a good regeneration potential, and some good papers about that, but basically it's always seen in all the papers that it has very good pain control. It's also non-invasive with no complications, so we decided to study what happened with both of them. This is our center in Bogota. What do we know? We know that the high-intensity laser, which is this one here, and the radial shockwave therapy, which is this one here, there are two non-invasive approaches that have been used for the treatment of musculoskeletal pain. So, is this good for ankle sprains? Haven't seen this before, but empirically my group has been using it. This or that, laser or shockwaves. We have been using these systems for many years, for 10 years now, and in approved applications, and also in musculoskeletal pain as part of the protocols of physical therapy. We are rather new in this, only 1.5 years, and this is all the knowledge that we have as surgeons of laser beams. We do know that these are class 4 high-intensity lasers, exactly the same kind of energy that we used for surgical applications, but this one is dispersed, so it causes biostimulation and also very good pain control. We know that not only us, but others in Europe especially have used this for biostimulation, anti-inflammation, analgesia, because it's very good short-term pain control and also has some vascular effects. The literature is rich now in certain publications, both in low back pain or in all these tendinopathies, in spinal pain syndromes, in chronic pain treatment, but basically also this in sports medicine. It's also very well used. So we are using this kind of lasers already, and remember last year we did another study comparing a combined treatment with shockwaves in elbow tendinopathies, and it was pretty good. So we hypothesized in specifically this kind of areas that the use of the mechanotransduction or photodynamics might improve pain control, reduce medication, allow a better rehab, and a faster recovery in second-degree ankle sprains, acute. So here's a study design. We had patients with, from our service with acute second-degree ankle sprains that were diagnosed by our foot doctors. We had an informed consent, 12 females, 22 males. The average age was 24, young people in 3 groups, a control group, a laser group, and a shockwave radial group. The standard treatment, we didn't modify this. Physical therapy, icing, bracing, medication, load control, crutches. And the laser group, we gave 4 sessions in 10 days, 4 watts, 100 joules, I'm sorry, per millimeter, an average treatment of about 7 minutes. And we changed our regular protocol to blind this. So instead of doing 2 sessions, we did 4 sessions in 10 days at the same energies, 4,000 shock waves under 2 bar of low energy. These 3 groups were evaluated blindly by evaluators for pain, function, rescue medication, and adverse effects. We not only used the Rolls-and-Modley scale, but also a functional score. This is the parameters of the control group. Immobilization, ankle bracing, or soft immobilization. Medication, the only one that we use is toricoxib for 7 days. And the use of this only if required. We record it if people needed or did not need medication. We use partial weight bearing and crutches for about 10 days. This is the maximum. Some patients didn't even use it for 3 days. And physical therapy is in 3 stages as usual. Pain and swelling control, range of motion, balance, and then sports gesture after 3 months. In shockwave, this is the protocol, 4,000 shots under 2 bar at a high frequency, usually 6 to 12. And the laser was for exactly 4 sessions, 10 days, so people would be easier to follow up. This is the Carlson and Peterson functional score for ankle. Pretty standard in foot surgery and very easy to understand. So these are the results. What you see here in blue is the people we did not intervene, the controls. What you see in green here is the people with the radial shock waves, and in red is the laser. So what you see here is the 4 sessions of treatment, and then after 3 weeks, 6 weeks, and 12 weeks, the final follow-up. So you see, this is a pretty benign type of lesion, and most of the people just get a good result just with physical therapy. Here you see there are only slightly significant differences at the beginning of the sessions, but in the end it's pretty much the same with the shock waves or the radials. And then the laser did have a very significant difference at the beginning and in the end also. If you can see it more specifically here in this graph, after 3 weeks, this is lasers, and in green is radials. You have a significant difference in pain reduction. This is the percentage of pain reduction. So we reduce the pain in 42% as compared with 27% here. And then after 6 weeks, there's also a very highly statistically significant difference of 29 against 12. And then after 12 weeks, there's no difference. It's 7 to 5, so it was no difference there. In function, there were no differences really. Here you see poor, fair, good, and excellent in the control group, in the laser group, and in the radial shockwave group. You are allowed to have 1 bad slide in every conference. This is mine. So what basically you see is the good results go up, and it's pretty much the same curve, and the bad results go down, and it's pretty much the same curve. But if you go to the specific Carlson angle scoring scale, the results were pretty much the same. They only might be a difference here, but it's almost in the edge. I would say it's a non-statistically significant difference, even though the laser group had a little better function in the beginning. But in the end, after 12 weeks, they were basically the same. This is interesting. Pain rescue medication. How many pills did you take? The people in the control group took 14 pills. With laser, 6. With radials, 11. And this, if you put this in statistics, is very significant. So you did have a less amount of medication required in those patients. The conclusion is that the patients with the high-intensity laser had a significantly better pain reduction during treatment, as well as in 3-6 weeks after treatment, not at 12. And the patients with the radial group had significantly similar results as the control group. In terms of function, the Rolls-and-Mosley and the Carlson scales did not show any statistically significant differences between groups. So basically the function is the same as just pain control. In medication, the pain control was 58% lower in the high-intensity laser group, whereas it was 22% lower in the radial group. So there's a factor here that is very interesting. We didn't have any weird complications, so we didn't have anything to worry about. Nothing as adverse effects were reported. So we can conclude basically that both of this technology improve somehow pain control in the treatment of acute second-degree ankle sprains in our series. We know that it was better with laser than radial shockwaves in pain control and rescue medication use, and there were no differences in function. We do recommend the use of this kind of technology, the high-intensity laser therapy, for pain control, and we're using it also, as we were talking this morning, for pain control before shockwave therapy in some cases. We do recommend the use of radials in chronic ligament-related pain and tendinopathies, but not in acute. In acute, I use this. In chronic, I use this. My recommendation is that, like our unit, we have all kinds of devices. We have the operating room, on the other side is skin, and the other side is urology, and downstairs in the operating room we have bone. And this in the sports area, well, we have the devices for all tools available to treat our patients, and that is the final advice that we have. But as this is my final conference, I have to say that I'm very thankful for everything. It was a very nice audience all the time. We had the opportunity to meet legends of shockwaves and share histories and the history and our private stories here and there. All of us as speakers are very grateful for the way that we've been treated. We had the chance also to welcome the new president, vice president of the present and future of the Federation of ONLAT. Thanks to Jose, thanks to Silvia, two of the best. And especially thanks to Danielle, who was absolutely a great host for us.